renal pathology, acute cystitis, as well as pyelonephritis. All right, so for the next pathology video, we're going to just be discussing acute cystitis as well as pyelonephritis. Now, the difference is, first and foremost, let's talk about acute cystitis. What do we need to know? All this is a UTI. All right, acute cystitis, same thing as a UTI, urinary tract infection. It's an ascending infection, right? Starts down and then it travels up the urethra, causes a UTI, urinary tract infection. All right, so you get an inflammation of the urinary bladder. Okay, so that's all that's occurring. Now, the patient's going to present with suprapubic pain, urgency, like they need to go to the restroom all the time, urinary frequency, but they do not have, and this is very key, they do not have the systemic symptoms like fevers or chills, night sweats, stuff like that. They don't have that. That's very important to understand. Okay, the risk factors include female sex because they have a shorter urethra, allowing for the rise of an ascending infection. Okay, quicker to get to the bladder. Sexual intercourse, not like very high yield to understand that an increased risk with sex, right? And then catheter usage. They love to talk about catheter usage. If you have a catheter that's in 24/7, 365, if you have a catheter that's placed in like longer than 48 hours, I think, then like hospitals are going to be pissed at you because it increases your risk of having a UTI, acute cystitis, by like 1 million. So take it out. That's a question that they love to ask. I don't even know if I've seen it on the boards. They might ask it, but like they love that even for your clinical rotations. Know that the catheter is a big, big problem when it comes to UTIs. Okay, you got to be changing that out. You got to be on the patient, making sure that it's okay. All right. Now, causes. The causes, number one cause all the time, 24/7, 365. If you have a pulse and you're breathing, you should 110% put E. coli right here, okay? It is the most common cause. It is the most commonly tested question of all time, 24/7, 365, okay? Acute cystitis, UTIs, what's the most common cause? E. coli. Boom. End of answer. Move on, okay? Now, you might be like, oh, Nate, well, what if it's a sexually active young woman? I remember learning about that Staph saprophyticus. That can cause UTIs, right? Yeah, well, if the vignette says it's a young sexually active woman, then what's your answer going to be? It's going to be E. coli. It's not Staph saprophyticus. Don't put Staph saprophyticus unless, one, they got rid of E. coli, and two, they're discussing or they're explaining the signs of Staph saprophyticus, okay? They're going to have to give you a lot more detail if they want you to put Staph saprophyticus. But for everything, put E. coli, okay? Lastly, if it's an ammonia scent, then Proteus mirabilis, okay? So if they're describing specific types of microbiology, then go with that one. If it's not talking about E. coli, then go with the other ones. But majority of the time, I'm talking about 99% of the time on these exams, put E. coli, okay? Please. Now, what are the labs going to look like? Labs look like positive for leukocyte esterases, positive for nitrates, okay? Very important. That's it. That's what it's going to tell you. Now, what you're going to see, however, in some patients, if there's sterile pyuria, so essentially you have negative urine cultures, but you have these positives, it could suggest not UTI, but rather it's going to suggest a gonorrhea or chlamydia infection, like an STD, all right? But that's later on for repro or micro, honestly. And then acute cystitis overall for UTIs, how do we treat it? We treat it with antibiotics, TMP, SMX, which is our sulfates, and then nitrofurantoin, but we'll get to those later on, all right? Perfect. UTI, you got to know it, easy. Next, pyelonephritis. So, for pyelonephritis, there's two separate, acute pyelonephritis and chronic pyelonephritis. The question is, what is it? Well, we talked about acute cystitis being inflammation of the urinary bladder. Pyelonephritis is going to be inflammation of the actual renal interstitium, okay? So it's going to be at the location of the kidney, okay? So we've had, essentially, a lot of the causes could be reflux nephropathy, but you have a backup all the way up to the kidneys causing the infection essentially went all the way back up to the kidneys. So you could have acute form of that, or a chronic form. So the acute pyelonephritis, you're going to have neutrophilic infiltrate in the renal interstitium, and the patient's going to actually present with systemic symptoms. Unlike acute cystitis that has no fevers and chills, this one will. Acute pyelonephritis has fevers, flank pains, chills, nausea, vomiting, right? Things like that, okay? One of the causes is a ascending UTI. So the UTI went from the bladder, and then it went all the way up to the kidneys. And how can we see this? We're going to see white blood cells in the urine with or without white blood cell casts, okay? So if you see white blood cell casts, this is one of the things that you should be looking out for, acute pyelonephritis. There's also a higher yield pathology, which we'll get to, that has white blood cell casts that you should 100% be thinking of. But this is also another one with white blood cell casts, acute pyelonephritis. Okay? That's all you really need to know. Next, for chronic pyelonephritis, this is something that they might ask more about. You're going to see coarse, okay, dilated calyces and bilateral cortical atrophy. Okay? Blunted calyces, dilated calyces, bilateral cortical atrophy. If you see any of that, think chronic pyelonephritis. Also, Chronic pyelonephritis is highly associated with patients that have vesicoureteral reflux, which we talked about at the beginning of the chapter. Why is that the case? Well, because if we are constantly causing a reflux of the urine back up to the kidney, then we're going to get a chronic inflammation of the pyelonephritis, right? So we're going to get chronic pyelonephritis, all right? Lastly, what you're going to be seeing on histology is thyroidization of the kidney. I don't remember seeing too many questions on it, but just know what the kidney looks like. It's something that's odd. That's all for acute cystitis and our pyelonephritis. Stay tuned for next acute kidney injury.